side. It's been a privilege and an honor to have such a guest speaker like Dr. Kevin Hart here on Aruba. And he is a board-certified pediatric dentist in Chicago, but also a Master of Science degree in human nutrition and dietetics, and many other very important accomplishments. And I want to thank also personally my colleague, my dear colleague, Dr. Martin Pannaralla. Without his help, none of this has been possible. So he has been in communication with Dr. Boyd for more than a month now. Invited him to come meet this beautiful island, first time this year. So we want to thank him for being here and thank him to take his time for us. So we move forward days before we introduce Dr. Kevin Hart. Here's my colleague, Dr. Marvin, who has a few words for you. Thank you so much once again for coming.
Hello. If we're losing hope,
This here.
Good afternoon. His Excellence Mr. Pista. Here. Fellow healthcare providers and guests. I'm Morgan Vanderbilt. For those of you who don't know me, I'm a dentist. Ever since I was 7 years old, I always knew I was going to be a dentist because I used to carve teeth on chalk all the time. And my mother was really worried. It was a weird practice. Anyway, that hobby became a career. And eventually my career turned into a passion. And I had a great opportunity to meet wonderful clinicians and scientists who share this passion. One of them is Dr. Boyd. It's a real honor to present to you guys to my dear colleague and friend, Dr.
Was that it? Okay. Probably don't even need this one. Well, thank you, Dr. Visser. So honored that you're here, honored guests. Appreciate you all coming for this. Martin and Mr. President, I'm just really thrilled to be here. My 17-year-old daughter is back in the hotel right now. Marvin and I, when we talked about this, I said, Marvin, you know, my daughter just been through a real rough term in school. She got all A's, but it took a toll on her. And I was looking at her and I said, this kid needs something. And I literally emailed Marvin that night and I said, Marvin, you've always been interested in my anthropology research. And he sometimes, like at meetings in LA, he went out and bought a backup drive so he could take some of my slides. This guy really likes my stuff. I like him. So I emailed him and I said, boy, is there any way you guys are going to be around? And I gave a narrow amount of dates. And do you think I can look at some archaeological specimens for I'm going to be entering a PhD program in anthropology if I'm so fortunate. I'm still finishing the prerequisite work for it. But I'm 58 years old and still don't know what I want to do for a living. Anyway, so Marvin emailed back and I'll start working on it literally within about a week. 3 stars aligned. He was going to be in town. The Dental Society was interested in listening to me. And the museum gave me permission through my university and everything. We went through a lot of red tape and things. I got permission to analyze some of the valuable specimens you have on your island of ancient prehistoric skulls that I'm doing, for my research. So, so here I am. I'm absolutely thrilled to be here. So, getting to move along here, we have a problem. Now, who is we? We have a problem in America, the United States, and the rest of the world that is exposed to Western culture. including Aruba. This report that Dr. Visser put together, I've really gone over with a fine-tooth comb. I've gone over lots of policies about the child obesity problem. Dr. Visser gets it. There's things included that I'm going to highlight today of the things that he addresses that some of the other countries are not addressing. I think they're key to solving the problem. So we collectively, as westernized countries, we need to work together to solve this problem. And we, in the allied health professions, need to work together to solve this problem. Okay, so it's a big we, and this is all about collaboration. That's what I'm going to be talking about today. The diseases that we're talking about are called chronic and non-communicable diseases, as opposed to infectious diseases or genetic diseases. Chronic and non-communicable diseases all share one thing in common. Okay, they are first preventable in a person who's at risk, either through their genes or environment or both, because they always work together. They are reversible if they are identified. If an at-risk individual is identified early enough, the disease is totally reversible. It is second, if it's not reversed, prevented, it is treatable or manageable with certain care. Diet and drugs and exercise, there's all kinds of things that can work together for that. Fourth, and this is the most important thing, but take it home, please. This is a take-home. I'll be telling you what take-homes are. I don't have it all on, but I'll tell you what it is. Fourth, they are potentially fatal. Morbidity and mortality. Western diseases, diseases of civilization, chronic and non-communicable diseases, they're all the same thing. Okay? They are all potentially fatal. They will end the life sooner than normal, and they will decrease the quality of life. Morbidity is increased when these diseases are present. Okay? Now, most people understand what a Western disease is. Diabetes is the perfect one to understand, type 2 diabetes. Okay? How about tooth decay? That is a Western disease. It follows that whole pattern. It's preventable, it's reversible, it's treatable, and it's potentially fatal. Malocclusion. You ready for that? Crooked teeth. Crooked teeth. Malocclusion is not a disease entity in itself. It is a symptom of jaws that cannot accommodate a tongue in an upward and forward position from birth to death. And this is all evidence-based. This is not conjecture. And I will develop this argument as we go through and provide evidence for it. So there's a paradigm shift. Excuse me. The other great equalizer is the survival necessity. What? Food, water, activity. We all know that, right? Air, food, water, activity. Did I leave anything out? Sleep, hygiene. This is new. This is within the last year. Longitudinal data. 11,000 children over 8 years in England. In the United States, there are 2 studies that confirm the same thing that the England study did, is that children who are not getting enough sleep in infancy and early childhood are setting themselves up for brain damage. Now, that's not meant to be hyperbolic. I'm not trying to be overly exaggerating here. It's true. It's medically defensible. There's evidence for this. So, here we go. The second reason that I came, the first reason was the problem. The second reason I came here is to gather data from my research, which I will develop through the talk, and if there's time, toward the end, I'll show you some of the measurements I did yesterday. You've got a wonderful archaeological museum here. Great resource. We can solve this problem, and I defined who we are. CLOCC, C-L-O-C-C. Oops, didn't want to do that. Okay. CLOCC stands for Consortium to Lower Obesity of Chicago's Children. Chicago has over 2.5 times the national rate for preschooler obesity. Okay, so we've developed a consortium there, and there's a small group of dentists, of which I was, the first one that was interested in this because of my nutrition background, to try to get physicians to understand they have a huge resource. They can raise their manpower by recruiting the dental profession to this problem. Tooth decay, obesity are both driven primarily by fermentable carbohydrates, starches and sugars. This is also medically defensible. This is the book that is just released, that's Dr. Visser's copy from the author, that shows that both obesity and tooth decay in little kids, and it's true in older kids too, but I'm focused on preschoolers, is a proxy. It is a indicator of unhealthy eating. Now, cross-sectionally, you won't find fat kids with crummy teeth, not all the time. You will find overweight kids that may have perfect teeth. You may find kids with awful teeth in normal weight. So it's not borne out in cross-sectional studies, one at a time. That's the lousiest research there is. Longitudinal studies, circumstantial evidence says, we'll bear this out. There hasn't been one study done yet. Pediatric dentists have access to records of kids they've done in the operating room. These kids can be retrospectively analyzed. I'm very confident the evidence will show that they're both proxies for unhealthy eating. They're surrogates. If you see a kid that's overweight, you know there's unhealthy eating. Okay? Activity, kids are lazy, that's nonsense. Okay? Kids need to be more active, but that is not what's causing this. Okay? Same thing with tooth decay. It's 100% preventable. The fact that smallpox got removed from the face of the earth because we know the cause. The fact that tooth decay still exists, to me, is a travesty because we know exactly what causes it. There's lots of factors that go into it, but given all those factors, if there's no sugar, there's no decay. Ask me how I know. Because tooth decay did not exist in the human experience until 10,000 years ago. Okay? And humans have been around how long? Does anyone want to hazard a guess of how long humans have been on the planet with the genome that we have now? If you could go back in time, open up the door, so I'll give you a hint, you'll be in Africa, and there's a person standing across from you that you would like to mate with, you could produce a baby who could also produce a baby. That defines the species, okay? So how far, does anyone want to hazard a guess as to how long humans have had this genome that we've been modern? Are you ready for this? 250,000 years, okay? That's how long we've been anatomically modern. It is probably longer than that. Evidence is coming in almost daily since they mapped the human genome and everything. So for, let's say, 250,000 years, we've gone without tooth decay. And what happened 10,000 years ago? We discovered agriculture. That's what humans learned how to plant food. What were the first foods? Cereal grains, carbohydrates. You cannot eat carbohydrates. You have to process them and cook them. We've had fire around for probably 500,000 or 600,000 years. So we've known how to stone grind and cook grains. So isn't that funny? The tooth decay appears about the same time as agriculture. It takes off with the, I think it's the Dutch West Indies imported the sugar. Is that, you guys would know more about that than me, but 1,000 Crusaders coming back from the Crusades, back in medieval England, they brought sugar back. And that's, tooth decay really started to take off. And then the Industrial Revolution of the mid-18th century, tooth decay went crazy. Guess what else started? Around the time of pre-Industrial Revolution, malocclusion. Malocclusion, crooked teeth and wrongly aligned jaws, did not exist in the human fossil record until about the times leading up to the Industrial Revolution. No impacted wisdom teeth. In fact, retromolar space behind those 32 teeth sometimes congenitally missing third molars, because we really didn't need them to survive, but we needed jaws big enough to accommodate all those teeth, because that meant they accommodate a tongue upward and forward off the back of the throat. If a baby would have had apnea, a baby never would have lived to become an ancestor. So we know that pretty much all humans, because they were breastfed into the third year of life for 250,000 years, okay, that stopped at the Industrial Revolution too. Think there's a coincidence there? Okay, so I'm going to continue to develop this, and I'm not going to talk that much on each slide, I promise.
Everything's bigger in America. We got the biggest cars, the biggest houses, the biggest companies, the biggest food, million Americans are today either overweight or obese. That's more than 60% of all U.S. adults. Since 1980, the total number of overweight and obese Americans has doubled, with twice as many overweight children and 3 times as many overweight adolescents. The fattest state in America? Mississippi, where 1 in 4 people.
So that movie was in 2003, so the data stopped in 2002. We have reliable data now for 2011, and it's getting worse. 2012 will be out pretty soon. It ain't going to be pretty. So we haven't really put the brakes on this yet. This is a very significant problem.
The biggest health crisis in American history. 34% of American adults, 17% of our children are considered obese. Obesity is the biggest threat to public health. In the last 30 years, obesity rates for kids have tripled.
So anyway, one heavy item. I was looking everywhere for this report. If you could get me a copy of it, but you know what? We're not alone. We all need to help each other. We're killing our kids. We're the first generation that is going to have children that will not live as long as we do, and they won't live as well as we do. But there's a time bomb about to happen. Dr. Visser knows about it. It's a tsunami that's coming in healthcare relative, because this started in the 80s, and the little kids in the 80s are now those numbers that were in the 90s and 2000 and above. So we got a problem. Dentistry is the key. And I'm hoping, Dr. Visser, that's the one message I want to get you, is that I hope that you will recruit the dental profession because of what we know about sugar already relative to decay. We can help. So you need us, we need you. And dietitians, school teachers, nurses, preschool teachers especially, and you'll see why preschool teachers. So here's my title. Again, public health diseases, but they're not really diseases, they're symptoms. And there's things that are related. This right here is also going to be, hopefully I will communicate this to you as powerfully as it's been communicated to me. Because I've changed the whole way that I practice dentistry since I learned about this. I've been trained in sleep medicine. Again, not that I'm a sleep physician or anything like that, but I've been trained to recognize craniofacial indicators of risk for sleep apnea, which is also a risk for brain damage. IQ, impaired IQ, ADD, things like that. So, and again, this is my evolutionary, background. There's a new discipline in healthcare education, mainly in training with physicians, called evolutionary medicine or Darwinian medicine. It's been around since the 90s and only now starting to take hold in some medical schools. There's only one program in the world that actually can get a master's in it, and I'm waiting for them to set up some sort of distance learning thing, because that's the program I want to be in. But until one happens in the States, I'm just spotting my time doing research and taking classes. So anyway, wrong diet doesn't just mean what you eat. That's the biggest component of it, but it's how you get it and at what stage of life you're at when you acquire food. And that should make sense as we talk. This is the lecture that I gave yesterday at the museum, and I'm going to be incorporating some of that material. And at the end, if people, because I'm going to talk, and stop me and raise questions. We got lots of time, but people can only sit still for so long. I'm very, this stuff is really interesting to me, so I think it's really interesting to everybody else. And you could all just be being polite right now. So I tend to try to move along.
News tonight from the largest government study of dental health.
Can you hear that okay?
In the century. Cavities are on the rise in very young children in this country. Our chief medical editor, Dr. Nancy Snyderman, is here with more on this. And Nancy, first of all, how young and what did the study find and what's behind all this?
The study did look at children ages 2 to 5, but we normally think of our toddlers having their baby teeth. And it was 2 snapshots. The most recent being between 1999 and 2004. That compared to one just a few years earlier. And the incidence of tooth decay, cavities, went up to 28% from 24% which really worries people because if your baby teeth don't fall out when they're supposed to and they rot ahead of time, adult teeth do not come in correctly, and that means that you can have cavern teeth, abnormal bites.
It's pretty good for a physician. They don't get a lot of
So
dental
for people who may hear something about this and understand it's just about baby teeth, it isn't just about baby teeth because of what can come after.
That's exactly right. And there's some culprits that this study really looked at. And a lot of them have to do with how we're raising our children, what we're feeding them. Processed foods, everything from little cheese doodles to raisins that stick on your teeth. Popular drinks, juices, soda, and interestingly, bottled water, which doesn't have fluoride in
We
it.
all remember the fluoride.
Absolutely.
Yeah.
Not having your children brush their teeth at least twice a day, and that means with parental supervision, making sure that they do it correctly. And you have to get your children to the dentist by the time of that first birthday. That makes a big difference.
So back to
Establish a dental home by age 1. Now, I know that that's, getting a kid in before the age of 3 is a tough thing to do, but we have to try to establish that mindset. It's like, what am I going to do with a 1-year-old? You can do a lot with a 1-year-old. Even if the kid's screaming maniac sitting in mom's chair, you're educating the mother. Get a look at the palate. After some of the stuff I show you today, you're going to see there's a lot you can do in an 18-month-old. Just by you can pick up craniofacial risk indicators of sleep disordered breathing, which sleep apnea is the worst case scenario. You can pick that up by looking at a kid, by looking at their palate, and by asking the mother targeted questions. Okay, so we know another thing that I've learned maybe from the anthropologist and not from my dental training is that malocclusion is set up in the first 5 years of life. I mean, you see a class 2 in an overt class 2 skeletal malocclusion, in a 2.5-year-old, it ain't going away. It's not going away. It's not, and it's a powerful risk factor for sleep disorder breathing. Now, I'm not suggesting orthodontists need to start treating 2-year-olds. This is what this message is. It's that we need to inform the parents. Your child is at risk for sleep disorder breathing, which is at risk for neurological development. Now what? Well, pediatric dentists, you got 2 of them on the island, general dentists, orthodontists, we need to work together. I have orthodontists now, the professor from the orthodontic department of the University of Illinois, he's referring now. Kevin, I'm not going to treat a 4-year-old, but you taught me something here. Let's work together on this. It's a beautiful world now. I have some great relationships with orthodontists in Chicago, and I just think that's the way the world has to go. So anyway, moving along. This is a metaphor. You guys all know what that is. That's a farm animal, right? This is a tough sell in Chicago. We don't have quite the diving material that you guys have. But I use this as a metaphor for the biofilm process of tooth decay and the liver disease process of fructose. Okay? So that's kind of obtuse, but I'm going to try to develop this, is that what you saw, okay, let's call that fermentable carbohydrate. Let's call that streptobutans, or let's call that hepatocyte. It's grabbing for that sugar, and it's laying down a deposit of plaque or biofilm, or adipose tissue, or fat in the liver. Okay, so it's a bit of a stretch, but fermentable carbohydrates, excessive fermentable carbohydrates, free access to inexpensive fermentable carbohydrates. The fact that humans we are hardwired to crave fermentable carbohydrates. Yes?
Give us an example of fermentable carbohydrates.
Well,
in the supermarket, what is that?
Well, first of all, you got a problem here too in your supermarkets because you guys use high fructose corn syrup, just like us. There's a few sodas that don't. Surprisingly, Coca-Cola and Sprite didn't have it. They use cane sugar. Okay? Now, it doesn't matter whether it's coming out of the ground as cane sugar or it's manufactured in the lab high fructose corn syrup. And I will explain the difference of what they are. But it's all sugars and starches. Starch is sugar. They're all glucose, just not as sweet. But if you put starch on your tongue and let it sit there for a while, it breaks down, so it's like sweet, like a saltine cracker without salt in it. You put it on your tongue, it breaks down, the amylase breaks it. Tastes like sugar. Yes, it is. White rice is sugar. White bread is sugar. Okay, high fructose corn syrup is a liver toxin, a dose-dependent hepatotoxin. So, does that answer your question? Yes. Okay. And the only difference is it's not conjugated with fiber. Okay? That's the problem. How come sugar never bothered us for 250,000 years? Well, it's because it was always conjugated with fiber, except us. You know. So, in honey, but honey was really cold, which is like fiber. All those vitamins that slow down absorption. So anyway, this is just a review for the dentists, which is most of you. How does sugar cause cavities? It causes irreversible binding to the pellicle or to the tooth. Okay, you can have initial colonizers, bacteria, but if there's no fermentable carbohydrate present, that will just brush away. Van der Waals forces, very weak bonding forces, will just brush flat off. You can lick it off with your tongue. But once this happens, once fermentable carbohydrate is introduced, okay, and the most powerful is sucrose, of which half is fructose and half is glucose. That's what makes it stick. It turns it into like an epoxy glue. It's irreversible adherence. Okay? So anyway, big babies, bad biofilms. I've given this talk is an evolution of a talk that I started 12 years ago. And I stay up every night before every lecture and I add stuff to it. So I wanted to make sure that you get your stuff in there. So I worked really hard on tailoring this for you guys. But this is a talk I gave, and this is where I first started coming up with this. If sugar's involved, which I learned from Dr. Lustig, in causing liver disease and tooth decay, we should be working together. And we should see, look at this, the same problem, the same age group, same time periods, is that you have a raise in preschooler obesity about the same time that you get an increase in tooth decay. Okay? That is not a coincidence. It's the same thing, causing both. Oh no, the kids are lazy. They're not exercising. Oh no, the kid doesn't brush. That is it. It's fermentable carbohydrate. Those other things are important. Kids need to exercise. They need to watch less TV. They need to brush more. Those are all true. But the main driver of both diseases is increased availability and intake of fermentable carbohydrates. So anyway, look what happens to go up with both around the same times. Okay? Decay, obesity, increased growers, and look at how much sweeteners have gone up at the same time. So this is, this is not a coincidence. I don't think it is. And we all got a problem here. These are some of the theories of tooth decay. They used to think it was internal, but I think it was Aristotle that says here was the first to identify it in the 4th century BC. 6,000 years ago. They saw these. He was a pretty smart guy too. So anyway, I won't dwell on this, but I know that there's probably some people here that aren't dental people, and it could be good review for us to really understand how sugar causes cavities. We know the relationship with sugar-sweetened beverages. It gets a lot of the focus, and it should, but those types of calories are not causing obesity. I mean, they're causing cavities. Okay, it's feeding the bacteria that cause them. But the increased calories that you get from this really isn't what's driving obesity. There's other things involved there, that dietary things, with fats, French fries, potato chips, and activity. But what sugar does is it converts obesity into metabolic syndrome. Now, metabolic syndrome is a cascade of things. It is high blood pressure, elevated triglycerides, insulin resistance. A couple other things. So you get different definitions, but it's a combination. Sugar is what turns it into that. It is mainly sugar in the form of fructose, high fructose corn syrup. Okay, so there's a lot of work being done on sugar-sweetened beverages, and I know Dr. Visser's working closely to try to engage the food and beverage industry. And I thought it was very interesting. He said, we gotta work with them. We don't want to put them down. We need to learn some of their techniques. Why are they so persuasive? How do they get their point across? We need to start doing that. So I think it would be a good alliance to help them be all that they can be. Like, make money and doing the right thing. I think that's kind of where a lot of policies are going now. Again, I emphasize, you won't necessarily see decay and overweight in the same child at the same time, but they are likely mutual predictors of one another because they are proxies for unhealthy eating. Okay? That is a hypothesis. I'm not saying that's a fact, but it's circumstantial evidence, lots to support it. So sip all day, get decay, it can even affect how much you weigh. We actually had a poster in my office with this. It's surprising, a lot of, it's like, oh, I didn't know that, This is Ansel Keys. Does anyone know of this person? He was a biochemist in the late 50s, early 60s, who came up with the lipid hypothesis for heart disease. And we now know that's nonsense. Saturated fat causes heart disease. It's not true. I mean, eating too much saturated fat is a good thing. Don't do it. But watch what we had to say. What he had to say is that because of his research, which you'll learn about in a minute, he said, eat less fat, eat more carbohydrates. So what? It gives you local infections. What are those local infections, my colleagues? Cavities. Do you think the American Dental Association got up in arms when he said that? No, they didn't. Now, I don't know that they were thinking, we're going to be in business. This is going to be good. But they didn't. They were asleep at the switch. We should have been all over this. What do you mean it's okay to get a few local infections?
If you can pack all of human history into 1 year, we've only been farming and eating grain since about yesterday, which is when we became shorter and fatter. We only started consuming processed vegetable oils about 10 minutes ago, which is when heart disease became our #1 killer. So after examining all this human history, the experts came to the obvious conclusion. We need to eat a lot more of these. And so they convinced us that human health depends on foods we didn't eat for more than 99% of our entire existence. How did this happen? In the 1950s, a biochemist named Ansel Keys published a study that compared heart disease and fat consumption in half a dozen countries. The more fat, the more heart disease. The trend line was unmistakable. Just one little problem. Keys left out countries where people eat a lot of fat but have very little heart disease, like Holland and Norway. He also left out countries where people don't eat much fat but do have a lot of heart disease, like Chile. In fact, Keys had reliable data from 22 countries, and the results were all over the place. But you can't make a big splash in the scientific community with a trend line that looks like this. So Keys did what any dedicated researcher would do. He threw out the data that didn't fit and published his results. His punishment for this bit of scientific chicanery was to get his picture on the cover of Time magazine. Keys became known as the father of the lipid hypothesis, which says that eating saturated fat raises the cholesterol in your blood, and high cholesterol in your blood clogs your arteries and causes heart disease.
So what happened after that is, I'm really entertaining you with video today. Fat consumption did go down after Keys, but heart disease didn't go down. Forget heart disease went up. This would also go down with carbohydrate consumption. That's what was driving heart disease. So again, heart disease did not go down. Sugar consumption went up in that span of time. So the few local infections that Ansel Keys talked about, that he sort of passed off as not being serious, can actually be, like I said, all chronic Western diseases that can be fatal. It's not common, but children die sometimes because of anesthesia accidents, sometimes because of cavernous sinus thrombosis to the brain, sometimes Ludwig's angina that suffocates a child from a lower infection. Very rare, but it happens. So tooth decay is a very serious problem. I'm attending in a pediatric medicine residency in Chicago, and because it's a high volume tertiary care hospital, we see more than we should. These things we got to it's a kid who died. Ludwig's angina. He's not one of our patients, but we have to report on this to our residents. Diamante driver is famous in America. He's an 8-year-old kid who died in Baltimore, and changed all kinds of policy now about kids having access to healthcare or otherwise. Again, tooth decay starts about 10,000 years ago. Jared Diamond is an evolutionary biologist, and he thinks that it was one of the biggest mistakes of mankind, the way they discovered it and what they did with it. Like a lot of things. Fermentable carbohydrates are not all bad, so probably find it hard for me to say that now, but it accounts for a population explosion from 10,000 years ago. I mean, we, for the most part of our entire existence, till about 10,000 years ago, there were only a few million people ever at one time on the earth. And now look where we are. And that's because of credit, it's the energy. That helps populations grow. It helps you live longer too, when you're active and when you're eating the fiber, okay? So we've learned to separate fiber from sugar, and that's what's caused all the problem. I told this is something that I want to bring to my profession, evolutionary medicine. I think evolutionary oral medicine. Don't doctors understand about evolution?
Do doctors already learn evolution as undergraduates? Is this not really a problem? And the answer is no. They don't know even the basics. This is a study we did recently, actually not 10 years ago, asking the deans of all the medical schools in North America how many evolutionary biologists are on the faculty. And of course, as you see, almost all of them have 0.
So anyway, evolutionary medicine is no way to practice medicine. It's a way to think. It's a thought process. Proximate cause of disease, that's what we're all experts in. We learned that in medical school, and whatever type of healthcare you're in. We learn about proximate cause of disease, but we don't learn about ultimate cause of disease. If we had these diseases early in our evolutionary history, we wouldn't be here today. Our ancestors wouldn't have lived to become ancestors because they would have never made it to the age of reproduction. That's one thing we know for sure. We can infer that by what we know now. And that's an evolutionary approach to thinking about disease. But you need to understand how natural selection works. Dr. Visser, Marvin, myself, our esteemed orthodontic colleagues, none of us had to take evolutionary biology to get into our respective professional schools or graduate training. That's a travesty. That's like an engineer not having to take physics to become an engineer. For us to not understand how natural selection works, there's no way we can understand ultimate cause of disease. So that's this is a new paradigm that, in the next 10 years, you're going to see this explode. I just happen to be around ground zero. Dr. Nessie is at the University of Michigan. He started this whole movement in the 90s. This is the book he wrote. I recommend it to anyone. Why would get sick? I just put fancy words in there. Why mouse get sick? It's the same thought process. And you need to understand how natural selection works in order for this to happen. So, the next thing I'm going to talk about is something called epigenetics. Have anybody heard of the science of epigenetics? We've heard of genetics. Okay. Well, essentially what it is, nature or nurture. You've heard that. Is it nature or nurture? There's no such thing anymore. You can't even ask that question and be articulately correct. Because since the mapping of the human genome, we now know genes don't act alone, the environment doesn't act alone. It's nature and nurture. So when you ask the question, you don't say, is it nature or nurture? You say, how is nature and nurture interacting? Because the epigenome, like the genome. So above the genome, Bruce Littler, who Dr. Visser and I are both mentored by, he's an evolutionary, he's a molecular biologist, originally in medical school at the University of Wisconsin, who pretty much brought this to the masses to understand about epigenetics. I'm going to teach you some very basic things that I've been taught in my training for preparation, for graduate school. It essentially says that our genome was set about 200,000 years ago. Okay, that there's not been macroevolutionary change. There's macro versus micro. Macroevolutionary change means you're a different species. Okay, we separated, and I'm sorry if this offends anybody's religious convictions, but you'll have to get over it because evolution is true. And we split from chimpanzees about 5.5 million years ago. We have a common, we didn't come from chimpanzees, we have a common ancestor with chimpanzees. And we split, okay? And the chimpanzees we see today don't look anything like the chimpanzee common ancestor any more than we look like Homo erectus. Okay, there's a lines that split. The human genome is 98.5% similar to the chimpanzee. Okay, that 1.5% difference accounts for a lot of difference in most of us. So, what the mismatch, this is one of the hypotheses of how epigenetics works, or how nature and nurture interact, is that we have a genome that was set literally hundreds of thousands of years ago. And whenever there were changes in environments like ice ages, and getting out of Africa and moving away from the equator, that accounts for how our skin got light. We got further away from the equator, we had to absorb more light to get vitamin D. That is the leading hypothesis for Caucasians coming out of Africa. Well, what happens is, over deep evolutionary time, genes have a time to micro-evolve. This microevolutionary change, like lactase persistence. A lot of people can't, after the age of 4, drink milk. Okay, well that's actually the normal state, but a lot of Western Europeans and other people, I can drink milk. It doesn't upset my stomach because the enzyme gets turned back on. It's a switch. So after the age of 4, I can drink milk, but Arthur can't. Okay, he's normal. I'm not. Okay, that's a microevolutionary change. It hasn't changed my DNA. It's not a mutation. It's a switch. That's all epigenetics is, and I'm going to teach you a little metaphor on how that works. And this is really where we discovered that malocclusion, our genome is designed for a masticatory apparatus to accommodate 32 teeth and a tongue in the upper 4 position. We pretty much know now that every baby that's born has the potential to have 32 teeth. Is it going to happen? Well, not for a while, because this is not really sunk in. And I know this is probably new for our orthodontic colleagues here, and it's mainly the anthropologists that have known about this for decades. And it's only now we're starting to communicate with each other. So, I will read this to you from Yoko. Dear John, you have ruined me for other men. I yearn for you. I feel nothing but heartache when we are apart. I'm so happy, Yoko. Okay, the metaphor is here. This is the genome, okay? This is what is read or interpreted. Genotype, phenotype. And we learned about Punnett squares and things in genetics, and little b makes blue eyes and stuff like that. Well, the little b, that represents the genotype. How it's interpreted, or the expression of it, blue eyes, that's the phenotype. Well, how John reads this message determines what expression he's going to have on his face. Now, this was taught to me by an evolutionary biologist, and I never forgot it. Okay, same words. There are no different words here. Dear John, you have ruined me. For other men I yearn. For you, I feel nothing but heartache. When we are apart, I am so happy. Okay? What do you think his expression is going to be? Do you think he's going to be happy? I mean, where'd you go? Okay, John. So, but again, that's kind of obtuse, it's oversimplified, but nothing happened to the message, there is no mutation. When you change nucleotide base pairs, adenine, thymine, cytosine, you know, the way they line up, that's a mutation. If that happens by copying errors, if it's genetic drift, if it's a mutation, that can be incorporated into the gene pool if it enhances survival over deep time. Well, if you don't change any words but change punctuation, you can change the expression, okay? And that's all that happened here. There's no mutation here. And it's modulated through 3 known ways for sure now. One is called histone modification. The DNA oils up so that when the RNA comes to read it, it doesn't see it all. And then after the RNA moves it, okay, we can unbind it. We don't have to hide anymore. But there's things in the environment that will trigger that. Methylation is another thing. We have these methyl groups to DNA, and it affects the way the message is read. The third one is microRNA. This is brand new, and this is something that Dr. Lipton has really taught me a lot about. Is that they can change the way, and you've heard about genes that are switched on and switched off. That's just an oversimplification for what epigenetics is. So it's important to have some of the things I'm going to talk about here. I just want to give you some working knowledge and read up on it. A great book called Mismatch. Is a great book on it by Gleckman. He's the Surgeon General of New Zealand, and he's an evolutionary physician. So, we don't need that. I was part of a consortium. The National Science Foundation put up a lot of money to send me, 6 other dentists, 3 pediatric dentists, and 2 oral surgeons, an orthodontist, and 2 general dentists, and 16 anthropologists from all over the world, and they sequestered us in a room for 3.5 days in a big room at Duke University and solved this problem. How is it that the dental profession doesn't know anything about evolutionary biology and how natural selection works? How is it that anthropologists and archaeologists do not understand the clinical importance of what they know? I mean, what the lecture I gave at this museum yesterday, those anthropologists were like, oh my God, we had no idea these specimens would teach so much to mankind, about dental disease. I was pointing things out to them that was taught to me by the anthropologists, and they were astonished. So we worked for 3 days. It was published in the journal Science, very prestigious journal, oldest journal, science journal on the planet. So this was very important. Here we are at Duke. That's the whole group. We call it EvoDent. You're going to be hearing more about this if I have my way. This is really important. The dental profession is going to become very valuable to this whole movement. So again, first, preventable lifestyle diseases. They're reversible, they're controllable, they're treatable, and they are potentially fatal. All of them. That's again, very important take home. Plaque-mediated dental disease is a disease. It's reversible. It's all those. It follows that same continuum. And mainly skeletal malocclusion. You don't find impacted wisdom teeth pretty much until about 300 or 400 years ago. Over 250,000 years, and then 350 years ago it starts. That's not genetic, okay? That's an epigenetic phenomenon. You'll find lower incisor crowding, mainly in mobility. It's interesting. I saw a skull yesterday with an impacted lateral incisor, and she was probably 500 or 600 year old grade. And I said, look at, she doesn't have any wear on her teeth, to the archaeologist. And I said, I bet you she was nobility, because she has a short maxilla. Cuspids don't get impacted when maxillas are forward. It's one thing I've learned. Since I've been bringing people forward, in the last 5 years I haven't had one impacted cuspid. And I said, I bet she's worth some nobility. And they all looked at each other and their jaws dropped. She's the only one that was in a casket. Okay? So that all made sense. So that was just sort of an evolutionary type thinking, this interaction with archaeologists. They were astonished by that. And then I was pointing out the airways. I had a lot of fun yesterday. And sleep disordered breathing, ADD, ADHD. I'm going to go through this stuff. I took fructose as a dose-dependent hepatotoxin. Look who has a policy statement against sugar. Not the American Dental Association. Do you know that? The American Academy of Pediatric Dentistry, the American Dental Association does not have a policy statement about sugar. That makes no sense. The American Heart Association does. So, is that something? I mean, I'm just like, some of the politics are astonishing to say the least. Anyway, we've been through this.
Found in all sugars and sweeteners and fructose. Foie gras is French for fatty liver. The delicacy, often sold as pâté, is made when ducks or geese are force-fed, causing their livers to fatten up as much as 12 times normal size. However, what's shoved down their throats is not fat, but corn.
In order to make pate, you don't feed them fat, you feed them carbohydrate, you feed them sugar.
Pediatric endocrinologist Dr. Robert Lustig of UCSF says he's starting to see fatty livers that look just like foie gras, but not in ducks or fancy restaurants. He's saying fatty livers in the bodies of overweight and obese children.
And if you look at the kid's fatty liver, it looks like pate.
Under a microscope, a normal human liver looks like this. Here's a fatty liver. All those white dots are globs of fat. What hurt their livers was not just excess calories, he says, but excess amounts of a molecule called fructose. And the trouble in the liver is causing another problem. See that dark stripe along this young girl's neck? It's not dirt.
It's a sign of excessive insulin, which is a precursor, in many cases, to diabetes.
Fructose is found naturally in fruits and veggies, but it's also found in many sugars, from cane and beet to high fructose corn syrup.
It doesn't matter if the sugar is coming out of the ground or being made in the factory. The bottom line is it's half fructose, and the fructose is dangerous.
A century ago, Americans ate roughly 3 teaspoons of fructose a day, mostly from fruits and vegetables. Today, we eat 5 times that amount, closer to 17 teaspoons a day. And it's coming mainly from processed foods and beverages. Sugary drinks, baked goods, cereals, snacks, and fruit juices. And growing evidence suggests consuming too much fructose over time is harmful. In a recent study, adults fed fructose-sweetened beverages for just 10 weeks gained toxic belly fat, boosted triglycerides, and became more insulin resistant.
Our livers can't handle that onslaught. It doesn't know what to do with it all. It turns it into fat.
The sugar and sweetener industries take issue with the research.
No kidding. So anyway, fructose is a carbohydrate. It has carbohydrate, just means one carbon, one water. The formula, the molecular formula for every carbohydrate, broken down into its individual component, is C6H12O6, which what glucose is. But glucose is a 6-membered ring, okay? It's a hexose, and it can be used by every single cell in your body. In fact, anything that's ever lived and ever will live on this planet utilizes sugar. It's the universal currency of life, okay? The lactose, which combines our glucose to form milk sugar, lactose, that can be isomerized, switched to glucose in an instant, and can be used for energy, not as readily as glucose. Fructose is not the same. It is a 5-membered ring. It's a pentose. It is a ketose sugar. Okay, glucose and lactose are aldose sugars. And our bodies, we evolved with it. We have enzymes to use them as energy. Fructose is recognized by the liver as a fat. The only way you can get energy out of fructose is if you are a high-performance marathon runner who depletes your glycogen from your liver, because fructose will help replenish liver glycogen. Okay, stored sugar. That's the only time. And that's not right. Who's drinking Gatorade? Not high-performance athletes. It's little fat children. They're drinking it. They're getting fat, and there's going to be a lot of liver problems. And all these kids on your island that have this problem, there's going to be hell to pay of what's going to happen to the livers. So, anyway, did anyone know that? That's foreign to everybody I tell it to. But I get lots of emails, and they just Google, everyone can check my facts, right? And it's like, so I got the way access to information is not. You gotta know, people are going to check up on it. Chronic fructose exposure is very similar to ethanol. The liver handles fructose is pretty similar to the way it handles ethanol. I mean, Lustig calls it ethanol. Fructose is ethanol without the buzz. You get all the back problems and all the fun stuff. So anyway, I went into your stores and took my little camera and Pepsi products, ketchup, barbecue sauce. You just read labels. Don't buy anything that says high fructose corn syrup on it. Not so much that it's any different really from table sugar, because they're very similar, but things that have high fructose corn syrup in it are cheaper to make, and it's an indicator of degree of processing. It's highly processed. When you have cane sugar in something, it's way more expensive. They have to be way more careful with their ingredients and everything. So try to buy it, and organic cannot have high fructose, at least in America. If it says organic, it can't have high fructose corn syrup. So, again, I went through this, is that the way the liver and the teeth handle sugar is they make a byproduct that's harmful. One is fat, the other one is plaque. Okay, so I won't, that's one of my favorite little diagrams. There's the difference between, glucose, fructose, but you have it.
Okay, joining us now, the director of the Weight Assessment for Teen and Child Health Program at UC San Francisco, Dr. Robert Lustig. He's out now with this is an extremely important new book, Fat Chance, Beat the Odds Against Sugar, Processed Food, Obesity, and Disease.
We're going to take a break after this.
If you eat, you should read this book. Okay, that means everybody should buy this book and read from it, because this is going to be cutting edge in terms of how we look at food, and specifically let's talk about sugar, which you lay the blame of obesity on sugar.
Actually, I really don't. There are lots and lots of ways to get obese.
Okay.
There are lots of different foodstuffs that contribute to weight gain. For instance, the Mozaffarian at Harvard School of Public Health showed that actually potato chips and French fries were probably the single biggest contributors to weight gain.
Absolutely.
The thing about sugar that's so pernicious is that it's not necessarily the cause of obesity, it's a cause. But it's the thing that takes you from obesity to all of the metabolic problems that occur secondary to obesity. That is, the lipid problems, the hypertension, the diabetes, the heart disease, and likely the cancer and the dementia. Conglomerately, we call this metabolic syndrome.
So we never had these problems before, okay? And it's mainly fiber. Fiber is the difference, and activity. We were very active, hunter-gatherers, nomadic. I said I was going to take a break, but I want to get to Dr. Visser. Are you all familiar with this, Dr. Visser? You've been in this. This is a great little thing. There's something missing from it but not that you missed it. It's just there's new knowledge out there now that I think you're hopefully going to add it, and I'll develop that as we move on. That's a great little algorithm. I really like it. Carbohydrates, I think, should be qualified. They need fiber. Okay? That's the only difference. And look at Dr. Visser mentions fiber. I had that underlined. I don't know what I had. See, it's underlined out here. You can't see it. But I count dietary fiber 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, at least 10 times dietary fiber is mentioned in this report. So that was impressive to me. Here's how glucose is metabolized, gets into the Krebs cycle, and you know what? If citrate does not get out of the mitochondria, you just don't have problems. And people who are active, and if you're not getting too much sugar in here, you know what? You just don't get problems, okay? But if you, this is how ethanol is metabolized. Unless, again, most people who drink too much, they're not really active. Citrate gets out of the mitochondria into the cytoplasm, and that's what happens. Citrate gets into our cytoplasm. It causes lots of problems. That's really how sugar is causing a lot of these problems. Well, fructose does the same thing. Not all the glucose that you eat, like if you eat sucrose, it's half glucose and half fructose. Not all that glucose goes to the liver, because it can be metabolized everywhere. Maybe 20% of it will get to the liver. But fructose, 100% of it, is the only tissue in the body that can really metabolize fructose is the liver, okay? And it doesn't use it as energy. It creates a lot of bad stuff. Now, I know I'm repeating myself, but this is really important. You have to turn ATP to ATP, you phosphorylate fructose to get it into the Krebs cycle. Well, that depletes phosphate and it causes uric acid levels to go up, which causes high blood pressure. Okay? So those are just a few of the things that happen. In nature, sugars, fructose, is always conjugated to fiber. Always. Always. 100% of the time. We only learned how to separate this stuff fairly recently. And that's why we just crave sugar. We're geared for it because it drew us to the breast when we came out of the womb, and it drew us to the healthy food, the fruits and vegetables. Okay? And we got the fiber, we got all the vitamins, and we got some of the energy. They've thrown away all the good stuff and they just give you the sugar. So this is a label reading cheat sheet. I think I'll take. Are there any questions? You've all been sitting, you've been patient, and nobody's fallen. I'm looking out here, everyone's wide-eyed. So I don't know what you've been using, but yeah, sure. So, I mean, why don't you get up and stretch your legs, get a cup of coffee, talk, or ask me questions, or do you want me to keep on? Because there's more. I gotta get to the sleep material, or you go to sleep. Yes.
So basically, fructose is really a problem when it's separated from fiber.
Exactly.
So when you're getting it from fruits and vegetables, it's
not a problem.
It's not a problem.
Can't.
Processes it slower, or
it processes it slower, and it processes it with cofactors. Now, what we hear how fiber is important for binding and for getting water into the GI tract and for binding. It's fiber, roughage, and all that. They're not telling you that's where all the vitamins and minerals are. It's attached to fiber, cofactors. So there's so much we do not understand about how vitamins and minerals and phytochemicals and traces minerals, how they work. They interact with the sugar. So we're taking pure sugar without all the cofactors. We have no idea what we're doing. We know we're getting disease from it. But that's really what it is. I mean, if you an antibiotic, a liquid antibiotic for a child, it's a sugar liquid in penicillin, right, or amoxicillin. What kind of parent would you be if you were a chemist and the doctor prescribed amoxicillin and you went home and separated out the amoxicillin and threw it away and just gave your kid sugar? That's what juice is. I mean, it just is. You're throwing away the actual medicine and giving the kid the sugar vehicle that, a spoonful of sugar helps medicine. Well, nature's known that. We learned that from nature.
Wait, can you repeat that? So if you give juice, you're basically doing that?
Yeah, the new rule about juice is if your child wants orange juice, okay, 6 ounces and 4 orange slices with it. Eat the fiber with it. They can have their orange juice. Get the most pulpy, fresh orange juice you can get. Minimize it to 4 to 6 ounces, every day or every other day, and make them eat the real fruit with it. If they want grape juice, make them eat grapes with the juice. If they want apple juice, which is the worst, make them eat some apple slices with it. Plain and simple. Don't tell them that you can't tell kids not to drink juice. I mean, it's just hard. It's part of their culture. So just modify the way they do it. You know what I do in the inner city in Chicago? Talking to these kids who are drinking Cokes and potato chips. Okay, no potato. You can have your Coke. Gee, you have to eat carrots or celery with it. I'm introducing fiber. Okay, well, it makes them feel full. It mechanically cleanses the teeth. It slows down absorption. But I just don't drink Coke. You can't do that. You can't take away the Coke. Especially in these lower socioeconomic areas. I mean, these kids, they got a rough life. They really do. In the inner city, in urban areas. So, I don't want to take away, their inexpensive pleasures, but I just wanted to use it as a teaching moment. Okay, go ahead and have it. Please eat some carrots. And we did a program at one of the schools where the White Sox play, and they were doing it. Because they were getting extra credit for it from the math teacher. So anyway, this is, do you want to take a break? Do you want to stand up? Yeah, let's get a break. We got cookies back there.
Twice as likely to develop a behavioral problems by age 7.
By age 7. It's a lot of kids. This just came out a year ago. And there's been subsequent studies, longitudinal studies with large sample sizes that have confirmed this data. So,
Now, like your preschooler, if it does, a study in the journal Pediatrics says it could be a warning sign. Researchers quizzed 249 mothers about how often their 2- and 3-year-olds snore. Those who snored more than 2 times per week eventually had worse overall behavioral functioning, especially with hyperactivity, attention, and depression. The study also found a strong association between persistent snorers and low socioeconomic status, being breastfed for less than 12 months, and higher exposure to tobacco. The author.
So anyway, I feel, and again, how many dentists in the room? Okay, so I'm sorry, if I've been talking too dentally focused here, I'm sorry. I thought it was me. So, please, if I'm getting too focused here, tunnel vision into one area, raise your hand. But I know we have a diverse group here, so I'm sorry if I've lost anybody in the first part. So anyway, the breastfeeding thing is real important to me. A lot of things that are talked about breastfeeding have to do with the nutritional superiority of breast milk over any sort of formula, which it is. There's no formula that even comes close to being the nutritional quality of breast milk. But what's often left out when we talk about nutrition or anti-nutrition, any type of nutrition implies nutrients, but that's not what nutrition is all about. How we acquire the nutrients, okay? How we chew them, how we acquire milk from the breast. There's a huge physical component to nutrition that is ignored in most nutrition conversations. We just want to, talk and isolate the nutrients, vitamins, minerals, and it's important. But I'm very interested in the physical aspects of nutrition. Sorry, we did that. So anyway.
Did you know sleep-deprived kids are at greater risk of becoming overweight, and as a result, developing type 2 diabetes and high blood pressure? The National Sleep Foundation offers these sleep guidelines for kids. For preschoolers, aim for 11 to 13 hours of sleep a night. For elementary school kids, 10 to 12 hours. For adolescents, 9 to 11 hours. And for teenagers, 8 to 9 hours. Starting your kids off with proper sleep habits gives them a firm foundation for a healthier future.
So, just like dental hygiene, personal hygiene, we call it sleep hygiene, of which quantity of sleep, all those hours, those are important. But because a kid is asleep for a certain amount of hours, that's a pretty good sign. It doesn't mean they're getting good sleep. It's just like when a fish jumps out of water. You can't see if that fish is just hovering underneath the surface of the water, or if it's going down and doing this. And that's what we do when we sleep. You've heard of REM sleep, rapid eye movement sleep. Well, in growing children, that's when they learn. That's when they consolidate memory. That's when they get something called synaptogenesis. When they get neurogenesis, they get new brain cells, they get new connections, they prune off old connections. REM sleep throughout the night should get longer and longer and longer. Kids who have sleep disordered breathing may be hovering just above being awake. How come? Because they're not getting enough air. How come? A lot of it has to do with the jaw architecture. Okay, and that does relate to how we're fed in infancy. So, who do you think is sleeping best? Anybody want to say? Who's probably getting the best quality of sleep out there? Okay, lips closed. Okay? Open mouth. Now, babies can open mouth, and they can still breathe through their nose. But if a kid's hanging their mouth open, it's usually indicative of tone issue, and that the tongue is not elevating up into the roof of the mouth. The tongue, one of the primary purposes of a tongue in the first 3 or 4 years of life is to build a nest for itself to live in for the rest of their lives. Why is it in orthodontics we always said retention is for life? When do we get rid of our retainer? At the funeral home. Okay, things are going to shift. Right? That's the only way we can guarantee. I mean, I don't know, that's how I was taught, by Bashar and Andreessen and the University of Iowa. Retention is for life. Well, that's, if a kid learns to position their tongue up and forward, the tongue acts like a rotator. It's a scaffold. They're highly unlikely for their, correction to become unstable. That's kind of new stuff. It has to do with transitioning from a suck swallow. When babies are born, they're programmed with a visceral swallow to suck. Okay? And that's how, that's how we got out of infancy and then to the age of reproduction to become an ancestor. That's really, we had to suck the breast exclusively for 6 months. That's what our ancestors did forever. And then to gradually transition from a suck swallow to a mature chew swallow. And usually by 3.5, 4 years old, when most babies were fully weaned, they had a mature swallow, up and forward into the roof of the mouth. That accounts for prehistoric lack of malocclusion. That tongue was up and forward all their lives because the breast and the chewing hard food taught the tongue to go from a suck swallow to a chew swallow. Okay, and the SL, there's a speech and language pathologist here, isn't there? An SLP? There was? Is. So you know this. But how come I didn't know? Well, because you didn't come and teach me in medical school. They didn't teach you. But she invites us to speech and feeding people.
You didn't invite me.
I know, it's our fault. No, but collaboration is the key. If you give a baby food, puree, Gerber, okay, at say 6 months old, what do? Right? They get milk because they have a visceral swallow, and eventually they overcome it. But they develop some degree of reverse swallow or tongue twist. And that is one of the main causes of malocclusion. It starts very early in life. And again, this is from the anthropology perspective. I'm trying to gather evidence for it, and I'm getting very lucky. So anyway.
2,000 children, and it was a population-based sample where again the children were born in utero. And what she's showing here is a progressive increase in the prevalence of overweight, really associated with short sleep in infancy. And you can see, in fact, when infants were getting less than 11 hours of sleep, the overall prevalence of overweight was about 14%, whereas when they were getting 13 or more hours of sleep, it was about 6%. But what was also, and in fact, she estimated and adjusted analyses that at age 3, overweight was twofold more likely in infants that were getting less than 12 hours of sleep per night.
Now, there's good explanations for why sleep is correlated to obesity, and I'll just talk briefly about it. A lot of, we talk about how obesity is a risk factor for apnea, but we don't talk about how obesity is actually a causal, it's sort of bidirectional, okay? In little kids, childhood obesity is, we don't know what comes first. The fat being accumulated in the throat, soft palate, posterior pharynx on the walls, or is it because they're not getting good sleep because of some other issue that affects their appetite? Or maybe it's bottle feeding and formula and other, I'm not claiming all the answers, but it seems to be bi-directional. They don't know which comes first, but they're definitely related. When we talk about what happens when an infant or anybody doesn't get good quality sleep, not just amount of sleep, but good cycling of sleep, of all the stages in REM sleep, it can affect hormones that affect appetite. Leptin is a hormone that tells you you're full, stop eating. People who become obese, and it's secreted from fat cells, their leptin doesn't work right. It's like insulin resistance. They have insulin, but it doesn't work because it's ineffective. Leptin, you can become leptin resistant too, so you're just hungry. And lack of sleep does that. You wake up craving more carbohydrates. Well, another one is ghrelin. This is secreted in the gut. This is something that makes you hungry. The other one tells you you're full. Leptin tells you you're full. Ghrelin tells you you're hungry. And this is increased. So leptin is decreased, ghrelin is increased in sleep deprivation. It's not good for anybody, and it happens across the board, regardless of your age. This is devastating to a neurologically developing child. But did I say something wrong? I saw somebody shake their head. I thought I got a fact wrong. Okay. Okay, so anyway, please don't hesitate to correct me if I say something wrong, but I haven't studied this stuff a lot. So anyway, I won't belabor that. But this is what happens, is that you get fat deposition actually in the soft palate and on the walls of the pharynx, which decreases the lumen, the area by which you can move air from the environment through your nose, the nasal capsule, into the paranasal sinus complex, and then down through nasopharynx, the oropharynx, the hypopharynx. Okay, so air can get blocked in a lot of places. Most of the time, we know the nasopharynx and the oropharynx and hypopharynx, that's really where it's happening. Most people don't have problems with their terminates, especially young kids, or their nose or nostrils. They deviated septum and things like that can figure into it. The reason we know this is I was speaking with our orthodontist here. I'm sorry, Dr. Walker? John. That maxillomandibular advancing surgery always cures apnea. You know what else does? Tonsillis and adenoid surgery in kids when they're large. So we know that this is primarily where the blockage is. Another sort of treatment that I do and Marvin does is called orthotropics, which in little kids, we bring that maxilla out forward beyond what the old norms, the old-fashioned norms say, oh, you're going out too far. Well, no, we're making room for the tongue. And then we wear a postular appliance. It's not like a functional appliance. It pulls back on the maxilla, but you have to willfully bring your jaw forward and hold it there. And that increases the airway and is long-term stable. Like McNamara and Lyle Johnson say at the University of Michigan, when you advance a mandible early in life, all you're getting is a neuromuscular change at first, but because you're getting their jaw forward, eventually the condyle will grow back and find itself on the eminence back toward the fossa, which is, again, I'm using a big word, but you know, your jaw does this. In a growing child, if you get them forward enough, it can change the growth direction of the condyles of where it stays stable, like for life, if you do it early enough and if you do it right. So anyway, there's lots of ways to increase posterior airway space. Okay, one is surgery, tonsillis and adenoids, maxillomandibular jaw surgery, or this other treatment that we're advocating. We're even thinking now, Herbst appliances. These are things that they anchor to the upper jaw and tend to have what's called a headgear effect. They pull things back and will restrict growth of a maxilla that's not quite developed right anyway. But if we put these kids in face masks, that would counteract the backward effect on the upper jaw. If we put kids in these things that help their jaws stay forward while they sleep, we used to just do it to kids with underbites. Now we're doing it to kids that don't even have underbites to give them more tongue space so that their tongue can come up and forward off the back of their throat. It's a brave world out there. There's some really new stuff, and I'm so pleased that everybody here is aware of airway. This is very encouraging. More so than I'm seeing in my own community. So breastfed under 12 months is a risk factor. How is it that breastfeeding is protective against so many things? Okay? And I hear people who acknowledge it. There's all kinds of studies that protect against obesity, hypertension, malocclusion, tooth decay, apnea. Breastfeeding protects against so many diseases that we call diseases of civilization. And I hear people say, what is it in the breast milk that is doing that? And it's like, it could be something in the breast milk. How about the mechanism, the physical mechanism by which a baby extracts milk out of the breast, training the tongue? Everyone seems to be missing this, and this is what I'm going to dedicate pretty much the rest of my career to, is trying to figure out how the physical aspects of infant feeding, not just breastfeeding, but chewing. And this is also a book. It's called Baby-Led Weaning. This is what people who aren't exposed to Western culture do. They let babies experiment and touch food that they can't. Babies don't have a pinching reflex. They can't pick up anything small enough that they can choke on. And as the pinching reflex becomes more refined, guess what else happens? The gag reflex gets closer to protecting the airway. It's a perfect system. So what hunter-gatherers, modern day hunter-gatherers that are anything left, or what our ancestors did, is they would let babies lick food, smell it, taste it, touch it, even before they had teeth, so that by the time they were able to chew, even if the babies could chew without teeth, by 6 or 7 months old, they knew what it looked like, what it tasted like, and they were eating and chewing on foods. And they were weaned over probably a 2 or 3 year period. And when you see how how babies extract milk from a breast by an ultrasound, this has only been discovered in the last 2 years, of what a baby's tongue does to develop the palate, not only laterally but forward. And if they're committed to chewing hard food, like our ancestors were, they're going to get beautiful palates, and they're going to breathe through their nose. And they're not going to get happy. So, I was asked, I was a keynote at the Academy of Breastfeeding Medicine. What in the world would you hear a dentist? And again, they were interested in the evolutionary approach to what I was doing. And pretty much, I was developing my thesis hypothesis that an ancestral pattern of infant and early childhood feeding versus modern feeding of children, infants, that's what accounts for the protective effect of the ancestral pattern. And that just means breastfeeding exclusively for the first 6 months of life, which the American Academy of Pediatrics says, the World Health Organization says, and loads of anthropology literature supports it, that that's what our ancestors did for years. And modern feeding is pretty much, that's what we all do. Formula. And even, when I ask mothers, did you breastfeed? Yes. Exclusively? Oh no, I don't. Oh, that's good. That's good quality of milk. That's not breastfeeding. Now, I'm not suggesting that when you breastfeed for 3.5 years, I'm saying that right now. What we need to do, orthodontists, dentists, pediatricians, we need to work together to come up with some way to teach a baby's tongue to lateralize, to transfer from an infantile swallow to a mature swallow. Okay, that's what breastfeeding used to do. Breastfeeding and weaning, it taught the tongue the right posture. Okay, if we use bottles and even with breast milk, if we're giving kids baby food, soft foods and purees, until we sort of can get back to put pressure on the industry to start making healthier baby foods and firmer foods, we have to find another way to teach the tongue to position itself correctly. So again, whenever I talk, there's someone who wants me to stay at home for 3.5 years. But that's not what I'm saying. So there's actually a substantial amount of literature in dental literature, orthodontic literature. The Angle Orthodontist is a premier journal in orthodontic science, and there are so many articles about airway, but they're sort of marginalized. But I've gone back and we've probably got 300 abstracts of orthodontic literature that says that malocclusion, or it alludes to that malocclusion, is an independent risk factor for sleep disordered breathing. But we're mainly work with is the high arched palate. See this? It's called an Ogabal palate. There's a Christian Guilleminault. Do you know that name? Gunny Walker Guilleminault at Stanford. He's a pediatric sleep medicine physician he's really, he's the one who identified in the 70s pediatric sleep apnea. And he feels that the shape of high arched narrow palate in a baby can never recover, and if it's not addressed and identified early. And it's done a lot of work with rapid expansion of faceless. So even kids who are class 3. So class 3
have revealed how babies breastfeed. It was previously thought that babies use a compression motion of the nipple to push milk out. But the new images show that babies extract milk by lowering their tongue to create a vacuum. The ability to produce a strong vacuum may explain why some babies are stronger suckers than others.
The base of the tongue widens the tongue. Okay? They used to think that the nipple got elongated back to the junction of the hard and soft palate. That isn't what, and that's how baby bottles that were designed. Okay? There is not one good baby bottle on the market. There's no such thing as an orthodontic pacifier or baby bottle. They're all bad. Okay? There's some evidence to say that a pacifier the first 6 weeks of life might make a child less susceptible to SIDS. So I won't refute that. But beyond 6 to 8 weeks, no child really should get a pacifier or a bottle. We have high-risk premature infants at Children's Memorial, Lurie Children's Hospital in Chicago. We cup feed them. They can lap it up like a kitten. This is another way a father can get involved with feeding. But bottles should be for emergencies. Sippy cups should be for emergencies. You should, as soon as if your child is on the breast, try to get them to a cup right away. If they're on the breast, keep them on the breast for 5 or 6 months. Don't let anyone discourage you. And your colleagues, your relatives, anybody, a woman should never be discouraged. As long as she and her child on breastfeed, they should be encouraged to do so. What happens here is the front part of the nipple wraps right around behind the front teeth, and the tongue, like a piston, it just drives it. Now, can you imagine if you're doing that exclusively for 6 months? You have soft, the baby soft spots, the fine ones, they're all over the face. I mean, it's just like the brain grows the cranium. There's no such thing as I inherited mom's small jaw and dad's big teeth. That is the biggest bunch of nonsense. It's just like I inherited, mom's small cranium and my dad's big, or my small brain, or whatever it is. There's no such thing as a mismatch there. Is that the growing capsular organ, whether it be the eyeball developing the orbit, the brain developing the cranium, the tongue is like an encapsulated organ that develops the palato-sutural complex in this direction and forward, and develops the tongue. The tongue builds a nest for itself to live in for the rest of its life. All kids, when they're born, their jaws are genomically designed to go the distance with 32 teeth, fully erupted wisdom teeth. We don't need wisdom teeth to survive, but we need a jaw that will accommodate them, because that means it will accommodate the tongue upward and forward off the back of the throat. Okay, now again, this is my hypothesis that I'm testing for my research. Okay, I don't know this, but I have lots of circumstantial evidence from anthropological sciences to say that this is an informed hypothesis, and it explains a lot of things, and I aim to get evidence for it. So, in breastfeeding, the tongue, the base of the tongue, develops across the mid. Everyone lick your tongue and rip your mouth. Feel that line up there, that your mid-palate suture? That's sponge when you're a baby. If your tongue is going up there, you're going to widen that palate in what we call transverse direction. And if the front part of the tongue is pushing, you have another one of the sutures. You can't feel it, but it goes behind the two side teeth, and it comes all the way up here where your nose and your frontal bone is called nasal. It develops the whole midface and nose forward. That accounts for prehistoric ancestral pronathism. That's what we are all designed for. That's what we're built for. The supplementary norms are the norms that we use in orthodontics to decide if the lower jaw's too far back, the upper jaw's too far forward. All of those were based on faces that were back because it was in the 1950s, and that was way after the Industrial Revolution. Everyone was eating modern food then and drinking out of baby bottles. Breastfeeding was almost a taboo in America in the 50s. This is what I did during my training at the University of Iowa, is that we had high-risk preemies that were intubated to their mouth, and they had their breathing feeding tubes taped up against the roof of their mouth, like a baby bottle nipple. And their tongues would go up there and collapse their palates. It almost looked like they almost had a cleft palate. Well, we started making these little plates that we would snap the tubes into, and look how nicely developed those palates were. And now we were the first people coming all over the world to learn this technique from us at Iowa. And now you've got most neonatal care units, they have these stock, where they can just put them in there, you don't have to do impressions for them. But, look at that. Now, to me, that's circumstantial evidence that a palate is very malleable, and that's the same shape as the baby's tongue. Isn't that something? The tongue's like a scaffold. That's why you never see a wild animal with malocclusion. Their tongues are always up and forward. They act like a scaffold. Now, you know, in the wild, I'm saying. There are artificially bred dogs, like bulldogs, that have hunger lice, and they die earlier, incidentally, because they have bad respiratory problems. So, again, this is high-risk breeding. In the old days, when they had tubes put in there, they would collapse pallets, but now we put it in these plates, and, you know, it's just unbelievable. Well, to me, that gives me more circumstantial evidence that breastfeeding and infant weaning accounts for setting a child up for a good occlusion. Again, just re-emphasizing, you have the mid-palatal suture, the transverse palatal suture. This is the incisive suture that many people think doesn't exist. It does exist. And it extends all the way up to Nazian, you know? So it really, if you've got a feeding situation that's conducive to pushing against that, it's going to stay that way. Question? No? Can't. All right, now here's another one for the SLP back here. This is a mature adult swallow, okay? Well, I don't know if the video is going to run on this, but you will see, just like in that ultrasound for breastfeeding, this is exactly what a proper adult non-reverse swallow is, or we call it a tongue thrust. Almost every human being that has some degree of malocclusion has some degree of reverse swallow, or lack of full adult swallow. They probably started in infancy. And that's why all malocclusions, it starts in infancy. Which means it's a reversible disease, a preventable disease. It's not a disease, it's a symptom. This shows this part of the tongue develops the most back posterior teeth. This part further up here, the tip of the tongue develops the front teeth. You will always find in nature, and again, we're animals. I mean, we're part of the animal kingdom. And this is, you know, the tongue is the scaffold for the shape of the palate and the dental arch. This is me back getting my degree, and through that, this is the research. I'm actually an undergrad in anthropology right now, just to keep, you know, getting prerequisites, but it's run like a graduate school in Northeastern Illinois. And I have 2 PhDs, dental anthropologists that are really helping me with my work. These are chimpanzees. We discovered this at the Field Museum, just going into the archival collection. These aren't age or sex matched, it's not like a large sample size. But the depth of this palate in this mid-palatal area, if I touched the 2 arms with my finger, it would cut me like a razor blade, even though that was this is 100 years old. Very small posterior airway, crooked teeth, over-retained baby tooth, cavities. Okay, this is a zoo-fed animal. Prior to 1970, the only way you get a baby chimpanzee into a zoo is to murder the mother. They were all orphans. That's how you got them out of the wild. So they had to be artificially fed. So that really is where this started to materialize, this whole hypothesis that I have about feeding. This is an animal that was a pet from 1926 of an anthropologist in the field in Africa. And look how flat the palate is. Look how straight the teeth are. And there's no decay here. This is carbon. So this was cavity-free, great occlusion, large posterior airway. Again, this is an older animal, but still, even taking that into account, this absolutely had to do with feeding. Chimpanzees breastfeed until 5. And they chew nothing but hard food. So anyway, we're trying to establish a sort of a cross-curriculum thing at Northeastern with your museum here. And the director, Raimundo, was, is he here? He's not here. But he was very interested in having possibly some of our other students come over here and maybe, you know, in the Netherlands, what's the institution? You know, have some sort of exchange. So that's another productive thing about this trip. So anyway, this is just illustrating the forces in ancestral feeding is out and forward, okay? They're inward and back in zoo-fed animals. And the way I started was I'm thinking we could take captive animals and have them be sort of a surrogate for post-industrial humans, okay? Soft foods, artificial bottle feeding, breastfeeding, and the animals in the wild are a surrogate for pre-industrial humans, or ancestral humans. We started to develop this whole protocol to study chimpanzees, and then we just said, we don't need to do this, we're going straight to humans. So I was crawling all over England last year looking at museums, and I was given access to the collection at the British Museum, which is essentially, it was in Winston Churchill's war rooms, and now it's all full of human skulls. And I was given access with 2 PhDs that are helping me find skulls and do data. So this is just what I'm doing here, is going to add to the collection of data. And Raimundo told me that he's connected to a whole Caribbean archaeological society that will be very interested in this. And plus at night, he's going to look into letting me have access to it there. So,
then the tongue drops through the top of the mouth and the upper arch.
So anyway, that's sort of an overdramatization. What happens when you don't have upward and forward tongue posture all your life? If it's down, the cheek muscles and everything can push in on your teeth. Now that not only can make your teeth crooked, but it can force your jaws back and prevent them from developing forward. This is the type of treatment that I do and Martin does, and it sounds to me like you're open to variations of this. This is brand new stuff, and it's not really out there yet. But I've been trained to recognize maxillary upper jaw that's too far back, even though a kid might not have an underbite. They have a normal overbite, but their upper jaw and lower jaw are far back, and it's difficult to recognize unless you get an x-ray and do a measurement, what we call assessing maxillary position. And I use Jim McNamara at the University of Michigan is a very famous academic orthodontist who's come up with a measurement where he calls it McNamara line. It comes down from the ASEAN point, and this point right under your nose, if it's on that line or behind it, even though you might get normal overbite, Dr. McNamara calls that maxillary protrusion. Okay? Well, we're saying that it should be way forward of that based on what we're seeing in our pre-industrial database. So we're putting a lot of kids, we widen them and we push them forward. Then some of the kids who are way back, we put them in these things at night that helps their upper jaws grow. And then we put them in what's called a functional appliance, but it's a postural appliance. It doesn't lock to the maxilla, the upper jaw. It sits up here, and the child actually consciously pulls the jaw forward, and it won't pull back in the upper jaw then. So you get it forward, you keep it forward, and you bring the lower jaw off the back. It's like the maxillary mandibular advancement. It brings everything forward, and it makes more room for air to come in through the nose. So that's called orthotropics. So anyway, problems, we have several problems, and the solution is collaboration. Dentistry, all branches of dentistry. And I'm thinking the archaeologists need to be brought into this. Again, they have something to offer here by teaching us about what our ancestors look like. Nose breathing. What is the advantage of nose breathing? Can anyone say one advantage of nose breathing over mouth breathing? Mechanical filtration. Yes, not just cilia, but you have inside the turbinates in the sinus complex. You have the lining can actually help trap large particles. What else? Another one? I'll give you a hint. Your air has to reach the alveoli of your lungs at 98.6 for maximum diffusion into the blood to the brain. So, unless you're in a rainforest, you're not breathing in 98.6 degree air. So it warms it up. Our bodies are about 2/3 water. Is room air, again, if you're in a rainforest, yeah, room air might be close to that humidity, but humidifies, okay? So mechanically filters, warms, humidifies, and the part that's left out a lot is release of nitrogen oxide. The The linings of your paranasal sinus complex, the epithelium, contains a compound called arginine. It's an amino acid. When turbinates, these are folds inside your sinuses. Turbine is the root word, turbinates. It speeds up air and catalyzes a reaction, conversion of arginine to nitrogen oxide. Powerful, powerful antimicrobial. It's responsible for sterilizing mechanical filtration. It's why nasally inspired air is pretty much sterile. So why wake up the adenoids and tonsils? You know, you're sterilizing the air. Tonsils and adenoids don't need to get big. The reason tonsils and adenoids get big and block the throat, they're fighting infection and it's mainly for mouth breathing. Because you're sucking in dirty, cold, dry air and you're not getting any benefit from nitrogen dioxide. Now, the person who discovered this got a Nobel Prize for it. Not because of what it did in the nose, but what it did to the heart. Angina, you've heard of angina, the chest pain. What do you take for it? Nitroglycerin. Okay, it works just as the nitrile part of it. Nitric oxide, nitroglycerin, they have a similar effect. In the endothelium, it relaxes the smooth muscle. In the alveoli of the lungs, it facilitates diffusion into the bloodstream and relaxes the smooth muscle of the blood. You get more good quality air to the brain. Orally inspired air is emergency air. Just like McDonald's junk food is emergency food. When you're on the road, you've got to do something. Okay, it's junk air. It's just like junk food. Nasally inspired air is what especially every child should have the capacity to do. And that's what maxillary mandibular advancement does. That's what expansion and protraction does. That's what bioblock does. Whatever you can do for a child. There's also Dr. Walker, and I'm sorry, what is your name, sir? The other orthodontist? And there's three of them. But have you heard of tongue trainers, infant trainers? They're these in Australia. They corral the tongue to swallow in an upward forward position. You can actually put them in 2-year-olds. So who wants to treat a 2-year-old? I don't treat it. I'll treat it. So, I'll treat it. Yeah. But I'm certainly not suggesting that people who don't have a comfort level of experience dealing with real little kids should do this. But if a child is at risk, they shouldn't be told to wait until they're older. Okay? They need to breathe now because they got growing brains. These tongue trainers show a lot of promise. I'm not really promoting them here, but it's an attempt, and we all got to work together to find ways to treat these problems really early, identify kids at risk, and treat when we can. Who knew about nitrogen oxide? I mean, one guy, two, three, good. You know, because it's not out there. They didn't teach it to us in dental school about this. So, that's what it's all about, nasal air versus orally inspired air. All right, sorry about that. Sleep is not a luxury. It's a necessity. There's a bidirectional association between certain craniofacial phenotypes, and we're talking mainly crossbites. Retrognathia just means backward, whether it's lower jaw, upper jaw, or both. Hyperdivergent growth is a long face. You've heard of long face syndrome or adenoid face, we call that. And another thing besides physical things that we can identify with kids, and any pediatrician, SLP, anybody, school teacher even, dealing with children by asking a few questions, or a preschool teacher seeing kids at nap time snoring. Preschool teacher can tell the parents, you might want to know, I've heard this is an issue. I'm doing in-services for teachers in preschools in Chicago. I've got 3 scheduled next month because they're seeing it more than anybody. But just asking simple questions at the dental office. Does your child snore? Does your child grind their teeth? You ever heard of that one? That's a risk factor for a kid trying to wake themselves up to get more air to their brain. Unequivocally, in an adult it could be stress, and a child is not stressed. They're trying to wake up. They're trying to get to a higher level of awareness in their sleep. Bedwetting. Huh? You ever heard of that one? I didn't know this. And I've been expanding kids for 25 years for crossbites and things, and I had parents tell me, stop up this bed when you expanded it. And I thought, yeah, sure. But that really does, it's related. Restless sleeping, night terrors. I have a whole questionnaire. If anybody wants it, every single patient in my practice, I send this questionnaire home. And I've referred since July, probably about 25 to 30 kids for sleep studies. I'm the only dentist that can actually refer a sleep study without a physician's co-signature, because I've had more training in sleep medicine than most physicians have, and I don't have very much. But I can identify kids, and I'd love to help anybody who wants this. Email me, I can send you the forms. They're validated questionnaires from the University of Michigan. And you don't have sleep, you don't have a sleep facility here, so what are you going to do? I mean, that's part of the problem is we identify it and what, because there aren't a lot of sleep studies under the best sleep studies under the best of circumstances. We're lucky to have one in Chicago. But at least you can make the parent aware. And maybe the arguments do need to come up, or maybe they do need to be expanded in advance. So I'm just, telling you this is coming down the pipe, and we're going to need to know more about this. Orofacial myology. Are you familiar with oral OMT? These are SLPs that have special training just on posture and tongues. Okay, but that you can build the architecture for a kid's tongue to live up there, but if, say they're 8 or 9 years old and their tongue's always been hanging down, it's not going to know where to go. So what there's speech pathologists and dental hygienists actually that are trained in this to train the tongue with exercises so that they come up and forward. So these are all new things, and you won't necessarily have access to this. So anyway, this is the AAPMD is a consortium of physicians, dentists, and neuromyologists that are mainly based at NYU Dental School. And we're having this meeting in March, and Art's coming, and Dr. Walker's coming. Dr. Walker made me aware of a similar meeting on sleep dental medicine in Tennessee, and when is this one? June. In June. So if anyone is interested in this, come up to one of us about that. And this was actually Ron Emanuel, who's Barack Obama's former chief of staff. He's mayor of Chicago now, and he signed a resolution recognizing the importance of everything that we're going to be talking about to a child's overall neurological development and health. So anyway, I'm going to talk just a little bit more about craniofacial myology, morphology. Just like dark circles under the eyes in a kid, that's called venous flooring. That's another thing. Any teacher can observe that. That's not normal. That is not good. That's an indication that there could be risk for neurological damage if a child is consistently having darkness under the eyes. Okay, that is poor sleep. Okay, they're not getting enough good quality sleep. Just like grinding of the teeth, just like snoring, just like bedwetting. But malocclusion, narrow jaws, poorly positioned jaws, teeth that are crooked, cross bites, things like that, those are all independent risk factors. They not in of themselves. I'm not saying every kid with a crossbite has apnea. That's not what I'm saying. But they tend to cluster around no other physical and behavioral risk factors. And that's something that is making the dental profession, we are going to become very vital to preventing these problems and recognizing them very early in life. It's an actual patient. The mother sent this to me. And, what can we do? What can I do for that kid? I can't do anything. And I'm an aggressive pediatric dentist in terms of, I'll expand it to your old parent will let me. That makes sense. But, it's sort of like, it's hard for some people. You want to put an expander in like 3.5-year-old? Yeah. It's not for orthodontic purposes. I use orthodontic appliance, but I'm doing it for breathing. And it will be for orthodontic benefits down the road. That's not what I'm doing here. But it is tough, in cooperation. I think right now it's a whole new world, just recognizing this problem. But we don't know what to do about it in a lot of these cases. It's just identified. Yes?
Is the mother trying to manually do the work?
Yeah, she's doing a manual. Yep, she's just doing a little chin thrust. It's like the anesthesiologist.
Did you have to stay up all night trying to get
No, yeah, you know what? She said that she feels guilty for not doing that every night. Is there anything you can do? Well, we haven't invented it yet. I think what we need to do is invent like a pin attached, like a lathing appliance. It's like a Herbst appliance that will help the baby, bring their jaws forward. Hasn't been done yet. We're just, we've opened, by discovering this, we've opened up a whole new set of problems. So anyway, this is sleep cycling. I told you REM sleep, it needs, this area under the curve needs to get, for healthy sleep, you need to do all the cycling, but REM sleep needs to increase throughout the night. So quantity of sleep and quality of sleep. And the only way you can assess quality of sleep is with a sleep study. And that's hooking a kid up overnight. It's expensive and complicated. So I'm not saying every kid has to do this, but if you got the resources, this is the best thing. We've identified 30 craniofacial dental risk factors, which I will send you. This is going to be published in Dr. Sheldon's sleep medicine text. He and I co-authored this chapter. We've actually cured some kids with BioBlock that were scheduled for mandibular distraction. And the surgeon said, okay, Cal, I'll give you a year, but I don't think it's going to work. And we used this BioBlock technique, and already we've cured 2 children and kept them off the operating room table. Cured their apnea just by doing this. They were very young. They started at like 4 or 5 years old. And the parents, they got it, and they helped. So it's not easy. It's not for everybody. This is called melancholy. That's how much of the uvula you can see when a child opens up. The more you can see, the better the airway. This came from anesthesiologists. They do this to assess intubation. But we can use this. But anyway, I've got 30 evidence-based craniofacial risk indicators. Some of them are on supplementary x-rays or CBCTs, 3-dimensional supplementary x-rays. That a dentist or certainly a pediatrician or any healthcare professional that's working with children, they can pick these up, and I won't go into them now. But this could be a whole lecture. And what I'm doing today, this is a whole day symposium that I, kind of got done for you guys. Again, this is the hyoid bone. It's like a kneecap. It connects to your sternum, your collarbone, your cervical spine, your tongue, and its position is indicative of risk for narrow posterior airway. Now, this person has a very narrow airway. We call this a high angle case, an open mouth. This is something, tooth nasal labial angle, 8 point, the nose is way behind that in real life. These are all things that this could have been caught, this could have been prevented. This is not genetic. It's not the whole genetic thing. Since the Genome Project, it's no longer even a valid term. It's genomic. It's epigenetic. But this person, this kid, was not destined to look like this. Here's another one. You can see how the airway is very narrow. The hyoid bone is way down here. Steep bending, like 8 point, way behind neck and real line. This airway is the only place it's not restricted is in the nasal pharynx. Now that might have been a kid who got the bad ones out, okay? But you know what? That's temporary relief for a lot of kids. Adenoids can grow back, and kids can have other reasons to have breathing problems after their adenoids. Jay Leno, who knows? Maybe if somebody would have recognized and expanded him and threw him in a face mask when he was 5, well, it would look like that. I mean, that's called mandibular prognatism, and it's just very rare unless a child has a syndrome. In non-syndromic individuals, excessive growth of the mandible is not common at all. It's mainly retromandibular or backward position to upper jaws. Now we're saying that even people who have class 2 malocclusion, they used to think the upper jaw was too far forward. It's not. McNamara showed that even them, most of them are too far back, plus the lower jaw. Curvature of the cervical spine. That airway is only that big because this person's doing this to get the airway. You straighten up that C-spine, and that person's going to close off. This is how we're trying to solve the problem. Okay? So anyway, there's so much you can pick up on a traditional orthodontic vital head X-ray. Class 2 malocclusion, again, this is McNamara, pretty much showed that you can identify it early in life, and it doesn't go away. It gets worse. How early can we pick up risk factors? There's a new thing called 3D ultrasound, and I'm working with an interventional radiologist in Milwaukee to try to follow some of these kids long term to see what happens. Now, if that was one of our ancestors and that kid breastfed, you know, the hypothesis says that, well, this kid could recover because breastfeeding will pull everything forward. So this kid wouldn't necessarily die, like a lot of kids who had problems in childhood, is that maybe breastfeeding rescued some of these kids. This is a background, this is an actual patient of mine who we're going to follow. Again, this isn't part of a prospective trial because we're just sort of sampling certain people non-invasively. And this is something, you know, I'm going to follow this kid, hopefully they stay my patient for 10 years. Yes?
I have a question. If this is based on our nutritional patterns and environmental issues, this is in the uterus, so it's not what the mother had consumed or how she consumed it, right?
No,
but it's not genetic either, so how?
Well, you know, again, you know, what's genetic? Maybe this kid is genetically predisposed. We don't know a whole ton about the genome. We've mapped it, we know where things are. Or it could be the way the kid's positioned. It could be the mother's diet. It could be, and there's so many things that happen in the womb that we don't understand. Epigenetics was essentially discovered because of what the Nazis did to the Dutch during World War II. The starvation, the Dutch famine. I mean, I don't know if anyone's heard of that, but the records were kept very closely depending on which trimester a child was in during the Dutch famine. 100% of it, 100% predictability of what kind of disease they were going to get in midlife. Anywhere from schizophrenia to diabetes, 100%. It's unbelievable. Read about the Dutch famine, epigenetics, just Google those two terms. So there's things that go on in the womb that we have no idea how it works. We just know that, you know, there's something about survival that what a baby perceives is on the outside world. They actually get prepared for it. Sometimes it's time released. It will not show up for maybe 40, 50 years down the road. This is a scratching the surface on the science. So these are also some in utero. I won't go on that. CPAP. This is one of the things that we do for kids who have apnea. Well, these masks, CPAP masks, they save the kids' lives because they push oxygen and it gets into their brain, right? But it's caving in the midface. So what we're doing is we're putting those face masks that we used, you know, that we put on underbite kids tonight. We put them on simultaneously. We've devised this thing to counteract the inward push of the CPAP mask. Well, I'm suggesting maybe biometers, first appliances, traditional functional appliances that have a headgear effect, but bring the mandible forward. Maybe we put those kids in face masks, and we can get their mandibles forward, we can get their upper jaws forward, we can help them breathe better, build the architecture, get them out of danger, and then just do some traditional orthodontic approaches that won't be intrusive on the maxilla. Again, just conjecture. Tracheotomies, we have to do that to a lot of kids. Mandibular distraction, we have to do that to a lot of kids. So, you know, this has changed. This is one of the earlier devices where we put a forward protraction with a CPAP mask to counteract that. I mean, you can take perfectly normal faces of kids and you can make them look like they have Down syndrome. You're saving their lives if you've got that CPAP on. But a lot of kids get their mid faces really pushed back when they're in CPAP. Constant positive pressure oxygen. Again, some of my archaeology stuff. You know, we just did this, and this was one of the first papers by Gilbert. that pretty much said malocclusion is a new disease. There was no need for you guys 350, 400 years ago. It just wasn't. Glad you're here now. Lots of need for you now. And again, Dan Lieberman at Harvard is the first to sort of say soft foods has something to do with it, but he doesn't go quite into the detail of breastfeeding. And he's been encouraging to me for some of the stuff that I'm trying to find evidence for. I feel the Industrial Revolution was a point of departure. Who were the first skilled laborers in the Industrial Revolution? It was women going into textile mills. What could women not do when they were going to work every day? Okay? What women couldn't do when they were in an agrarian lifestyle, when their kids were housed, they couldn't breastfeed. Okay? And before the Industrial Revolution, the factories, there was what we call cottage industry. Women were still in their homes. She's breastfeeding. She was making cloth, and a merchant would pick it up and sell it. You know, this is like the late 1600s, early 1700s. Maybe not that picture there, but it's sort of like women, when they start, they have to leave the home. They could not have the same commitment to breastfeeding. We know ancestral type infant feeding went on throughout human history, and that seems to coincide with resistance to malocclusion. Here's what I found. These are the cemeteries that I was able to look at specimens from when I was in England. And, you know, here it is. A point is always ahead of the McNamara line in virtually every skull that I looked at. And I looked at hundreds of skulls. The only time I didn't find A point from that line was mobility. Okay? And there were some places that were reserved in graveyards where mobility was buried. And they still had the wisdom teeth. They had straight teeth, but they had, you know, unworn cusps. They were not eating hard food. And they had short maxillas. And they had packed canine some of them. So, you know, we're not going to publish any of this yet because we have to put it in. Right now, we're just doing sort of pilot detective work and getting a feel for which museums will let us have access to what. But we found this pretty much in every single case when it was proletariat class, you know, working class farmers. Yes? And also, I mean, when you see in the literature an ideal face, you know, and again, this is an article that showed that the length of anus to ENS, actually no, they use horizontal vertical to A point, and if it's 97 millimeters or above, less susceptibility to apnea. This is a totally made up, constructed measurement. But it was done by an orthodontist, and he's written back to me actually. Dentistry, I don't know if you know him. But you always see A point ahead of McNamara line. Whenever you see an ideal skull, whenever plastic surgeons, you know, do this or refer to the golden, maybe something with a golden section of proportion of an ideal face, you always have A point ahead. You know, the front of the jaw. This just talks. This is McNamara's study. He found most people who have, you know, jaws like this, and they thought protrusive upper jaws. Most of them are not protrusive. The vast majority of them are retrusive. This is a 1981 paper published in a very prestigious orthodontic. And the standards to measure where a face should be in the cranial base, they were invented in the 50s, and it was very subjective. And a lot of them were based on a guy named Steiner, who used his own child as the ideal face of what everyone should look like. And this Dr. Caspel was at Iowa when I was there, and he published this paper. But he just pretty much said that, you know, the norms that we're using are subjective. I like the Bolton standard, which is a Case Western. It was a longitudinal database. It's actually still going on. It started in the late 20s. And 1-year-olds in the early 30s, they were in the SARS. Some of them are still in the study. And they're measuring, and we use these bold profiles of this is where a maxilla should be. And we like, you know, to get in earlier so that we can help these jaws come forward. It's not just about straight teeth. The straight teeth fit on jaws that are forward positioned in the face. This is an orthodontist at McGill, an academic orthodontist at McGill in Canada. And this is the first time I've seen this in the literature. Class 2 bimaxillary retrusion. Not protrusion, but retrusion. So I've actually been in communication with him. And so again, McNamara was trying to correlate cone beam CBCTs with standard supplementary analog films. And what did he use but a prehistoric face to test this? And I used to teach at Michigan in the Department of Orthodontics and Dentistry, and I had a desk in his lab, and I from time to time talk to him about this. And he just, he liked it because it was like, robust. But he didn't take any notice of that in his paper that Max Sully was a 5,000-year-old skull. We're trying to come up with the research that we're doing is a database that has a lot of points to establish a new norm for how genomically what our faces are capable of in terms of accommodating the tongue. The pharyngeal airway size became narrow after the treatment, meaning extraction. Now, sometimes kids get to us too late. Their teeth are so crowded, is that really it's next to impossible to get them expanded because their bones are so tight with conventional treatments. So they have teeth pulled. Well, there's sometimes no recourse to do that, but they found long term that some of these kids, they get their airways by getting the teeth pulled back, which is a jaw back. Now, this is a kid with Guillermo syndrome. Look at his chest. And he was scheduled for jaw surgery. He was referred to me from sleep medicine at the Children's Hospital in Chicago. We expanded him, and this is Piero Ben. Now, all of you agree that this is too far back. But look at the next thing is too far back, too. We never used to recognize that. So we put all these kids, we widened them, and we make them even more protrusive. Then we can really bring their mandibles forward at the base of the tongue, off the back of their throat. They have a marvelous airway response to this. And we're trying to get surgeons to not just move the mandible forward in these kids, but even bring the maxilla out. Even you can do that non-surgically before you do the surgical procedure with the mandible. This is BioBlock, how it works. It brings the mandible forward and the maxilla forward, and that in turn increases airway. Laminar flow, whether it's a liquid or a gas coming through a tube, okay, there's a logarithmic relationship between radius of the lumen and resistance to airflow. So if you just open up, say, you double the radius of an airway, by bringing that just a little bit forward, you actually decrease resistance to flow of air by a factor of 16. It's called Poiseuille's law of laminar flows from physics, but I didn't remember that. I probably memorized it for a test in undergrad there. Physics in action here. And this is a kid that's going to be Bill Hain, the orthodontist that taught Marvin me how to do this. This is a kid he treated from our hospital in Chicago. They actually flew to California on a monthly basis. And you can see what BioBlock orthotropics did for this kid's airway. Okay, and when you realize that formula is opening up his airway that much, decreased his resistance to nasal breathing, I mean, it was unbelievable. This kid was essentially cured of apnea, and he was scheduled to have his jaw broken. This is a polysonogram, which explains that last kid. All these numbers, if they're above 0, 1, 2, 3, that's bad, especially apnea. Down to 0 means cured. And this is that kid. And this is what his sleep study did. He was totally cured. And this is something we're going to publish in the textbook, because it's backed up. It's not just, the airway looks weird. This kid passed a sleep study with flying colors without his appliances, and we can see that permanent change. This is a child who originally was treated with conventional, it's called a Herbst appliance, that helped her jaw from forward, but it also kind of prevented her upper jaw from growing. So we retreated her with the biome. We expanded her, we brought her forward for her appliance. And I think most people would agree that looks better. in a scientific meeting, I would show you the supplemetrics. And she didn't have any sleep test or anything to confirm that, but and again, I've published two articles if anyone wants them on evolutionary dentistry, and this is also a study from China that showed that extracting teeth and retracting the incisors pushes the mandible back. So this airway went to this. This was an adult, but in an adult, what are you going to do? I mean, it's just patients have to be warned about it, but it's not to say that we shouldn't be doing this. It's just when a person's not growing, it's really hard to, if they have really crooked teeth, sometimes the only thing you do is pull teeth, but I don't know. It's just, a lot of this is frustrating. This is a child who came to me for a second opinion. They wanted to extract 4 bicuspids on this kid. The mom was a speech pathologist and heard me speak and asked me if I'd give this a look. And this was, pre-extraction. This kid already was way back, kind of vertical. The hyoid bone is pretty distant. So I suggested, non-extraction. This is her, and the profile is a little bit dished in. If this child loses bicuspids, that is probably not going to be good long-term for tongue space, okay? And it might not look so good either. This is her brother, same thing. And there were, this is pretty far, that next level is pretty far back. Palate's pretty deep and narrow. The mom, she said class 3's in my family. I wonder if my kids have it. She was always assured that they didn't. So again, I'm suggesting that children not necessarily be treated, but if the American Orthodontic Association would agree at some point that at least we can identify kids at risk even if we don't treat them. But certainly, like seeing a kid at age 7, maybe for the first time, well, that's better than seeing them at 10. But at 7, the maxilla is pretty much 90% of its adult size, if not more. So I think we all need to get a little bit more aggressive with at least identifying kids at risk, if not treating them. And what is it that I want to add to Dr. Visser's? What is the essential of life besides food, water, and activity? Air? There you go. So I'm hoping he sees this on film or something. I would love it to see it again. But, that's all I have to say. Any questions? Otherwise, let's go get a drink. Yes?
In your study, do you also need to position science for example, screen?
Yeah, I talked about we have craniofacial osteopaths in our group that we study with Dr. Hang, but it's just so foreign to me that I would love to get that training. I mean, I'd love to get a lecture in a tutorial. I'm impressed by it, but I don't know anything about it. I know about cervical spine, and oral posture and head posture. No, but it's something that's amazing. I know something about it.
The duration or the way the child performs, like for example, the C-section method.
Yes. Yeah. What Dr. asked me is there a correlation between mode of delivery, a C-section versus a forceps or a regular vaginal delivery or a difficult delivery? That absolutely can predispose a child to having issues with their craniofacial architecture, which can impact breathing and tongue posture. Again, my hypothesis is even in the presence of those risks, if a child is exclusively breastfed and weaned onto very firm food, I think some of those things might rectify. I don't know. Hypothetically, that's a very good point. Is it the way a child comes into the world? It could set them up. Or twins, or the way they're up against the uterus. I mean, that can impact it. So there's a lot we really don't understand. It's not just genetics, but it's environment of the womb. So Yes, Mark.
I think it's extreme the fact that the mother says class 3 goes to my family. Is it a habitual habit in the family or epigenetic?
Well, that's interesting. Robert Corricini is a dental anthropologist from Southern Illinois University, and he's measured literally thousands of skulls from thousands of different eras in time in lots of different parts of the world. And pretty much he has found that the genomically correct occlusion, the way the upper jaw and lower teeth come together, is right over one another. In that, what we call now underbite, like Jay Leno, a person who maybe had that genetic predisposition, say, 50,000 years ago, well, that means they were maybe back in the middle. It's probably that much, but now, something that is like that far back, it becomes that. It's much more exaggerated, but that's not to say that there isn't a genetic predisposition. The Habsburg jaw you've heard about, they used to sit, you always cite that as a genetic factor that causes malocclusion. Well, who are the Habsburgs? Royalty. Okay? And it was taboo for a queen to breastfeed her own child. You know, they were wet nursed, and they were fed refined foods. They had that. So, you know, again, nobility in a non-biological mother does not have the same commitment to feeding a child than a biological mother did. So, you know, the Habsburg jaw thing is pretty much, the anthropologists have been sort of poo-pooing that for a long time in terms of being a genetically caused disease. Yes?
So the biotopic treatment?
Orthotropics. Yeah. ORTHODROPICS.
For the most part, that's non-surgical and no extractions.
Exactly. Yeah. And sometimes non-invasive. I mean, the orthodontist who invented it, he's the one who crawled around Churchill's worms looking at the palmary skulls before me. He got me access to measure that. But that's where he came up with the premise. He was looking at ancient Roman cemeteries, and you know what? He just said, I'm going to expand them, I'm going to bring them forward, I'm going to posture the jaws forward. And I've seen some of his cases that are 30 years out, and it's just unbelievable. And he doesn't put braces on them. And some of them have little spaces, but there are just because he has such good tongue posture. And the teeth sort of form around the tongue from the inside, and the lip, if they have good lip seal, you have, you know, it almost like squeezes them together. You have your auricularis muscle and the cheek muscles coming this way, and the tongue opposing this way, and it tends to form a completely well-defined arch. So that's kind of how that works. The kids that I do orthotropics on, I pretty much, all of them, I say, I never promise the parent, look, this is going to be all done. Still might be some dental alignment. A lot of them don't need braces. You can do it with this thing called Invisalign. As long as you keep them forward and they're breathing and they're posturing forward, the Invisalign will line the teeth up and not pull things back. So, anyone else? Yes, yeah.
So, can you actually sort of spell out, like, if you were a mother breastfeeding, how long would you breastfeed the child? When would you start introducing these like the hard foods that you're talking about? Like, so you wouldn't even give them soft food.
No. And what our ancestors did in the first, I don't know, from 6, 7, 8 months of it's called kiss feeding or pre-mastication. They would chew the food like a bird does and spit it in their kid's mouth. But that's what we did forever. And there's people that are trying to get back to that. I don't think it's disgusting at all. I'm an anthropologist in training. It makes sense to me. Do you have a child? No. But I love your questions and the way you ask them. What is your teacher? This is a gift for you. But yeah, if I were a mother, all right, what I would do is if I'm like following an ancestral pattern of infant early childhood feeding, breastfeeding in, for the first 6 months of life, and that could mean 4 months, it could be 8 months. It could be up to a year. I mean, we have data from a lot of different places, and we can do radioisotope studies to find out, and the teeth have what's called a needle line, you can tell when a child was born, but you can also read the teeth because they're a record, they're a mineral record from when a kid stopped exclusive breastfeeding. And it's consistent throughout human history. About 6 months old. So most all the time, kids were exclusively breastfed for 6 months and weaned into the 3rd year of life. Tons of data to support that. That is the genomically correct way to feed. So, but given our culture, we've changed. We used to walk a mile every day to get water. We don't do that. We have hunger. We have to find other ways. And to do what? Well, to get the proper nutrition into a kid, to allow a mother to assume a rightful place in our political system, in our industry, and everything. And find a way to not only deliver the nutrition that breast milk is, but the physical challenge and teaching what breastfeeding does to the tongue, to teach it to go in the right place, to develop the palatal-facial sutural complex. It's a sutural complex like the cranium, soft spots. We have to find ways to do that so that women aren't tethered to the home. I mean, increase the availability of a place and teach people about being led leading. Put pressure on the food and beverage industry to start making things that aren't killing our kids.
Okay, but then after the breast milk,
weaning starts in about 6 months and extends into the 3rd year of life.
Then do them after that?
Well, okay, I'm sorry, I missed it. Is it no? A baby by 9-10 months old should be eating everything that you're eating. Okay, because that's what they had to do throughout human history.
There are a lot of things that you have to avoid allergies.
Well, probably some of the allergies are from the fact that kids aren't being weaned properly. Okay, that can go either way. But if kids were getting allergies throughout human history, they would not have lived to become.
Yeah, but then
It is in the food supply. It's problems.
The environmental
Right.
changes.
Right.
Because I have 2 children, and one I haven't breastfeed her, and she has no allergies. And the other I breastfeeded for 1 year, exclusively 6 months,
right.
All the way it has to be, and he's more allergic than anything in the world.
Right.
So I think I'm a physician, so I try to give them and to be very natural possible, but the environment, we have cellulars, there are a lot of things that change and modify.
Totally correct.
And,
the environment has changed
as
so
working mothers, we have that problem too, because I would leave my child to try experiment with this food, and it will take like 1 or 2 hours for him to start, because they have to be there, think what he's chewing, and
right.
But
I think what we try to do is, because I think that will be an outlier, is that we try to minimize the risk of failure. And I think by encouraging a mother to exclusively breastfeed for 6 months and wean out to as natural, unprocessed food, and get them eating what everyone's eating, certainly before 1 year old, that is going to minimize risk.
And parents will be on here, and we have a problem here. We live on an island, we don't produce much things, so
right.
Everything that we get is frozen or processed.
Right.
And then when the children start eating, you have to start. Here we start sometimes. We say we start with orange colored food, and then we start with green. But the oranges sometimes you get a pumpkin, and the pumpkin is so tight that it doesn't taste the way it has to taste. So it's a big problem that we have here.
Are you a pediatrician?
No.
But see, I'm amazed at how much you know about nutrition and how much emphasis you put on it. Because it doesn't really happen a lot. So you're already way ahead of the curve in my mind in terms of how much placement you put on healthy eating. And You're frustrated because of the processed foods.
Yeah.
I think that's the way medicine has to go in the direction that you are.
I have a question regarding the things to yours. What is your opinion on the nets? When my daughter was 1, I wanted her to go straight solids instead of baby food, and I bought this net online.
Oh, the you chew on the
Yeah, and what is your opinion on that?
I think they're awesome
Yeah.
because it's a food processor.
Exactly.
It's the child's own.
They gave them I did mine.
I actually have them in my office. So.
I don't think the item has it.
I had
Do you understand what they're saying? There are these little bags, they're like pacifiers, but they got these little nets on them, and you can cut up fruit in there and cut up vegetables to slightly cook, and the baby can start chewing on them, but there's no danger of choking them because it's in that bag, and they're sucking some of the nutrients out of there. Then you open up the bag, and the kids curate their own food, so you get benefit.
And it's wonderful when you're eating because it helps you with.
Yeah, you can put cold in there, and good point. Yeah.
And that's something maybe we should do on the island is nets. And that promote them to eat the direct mango and everything without us worrying that they're going to choke.
Yeah.
And that, I think that should
that to me is one of the solutions. What are we going to do? Women can't stay home and breastfeed. All this, and he's not going to want to expand that to 2-year-old. Maybe you do, but most of the time probably don't. But this is one of those alternatives that maybe that's the way we teach the tongue how to develop a mature swallow, chew swallow instead of a suck swallow. I mean, to me, those are the sorts of things that we need to come up with innovative alternatives to what our ancestors did, to get that, so that, he can concentrate on helping kids breathe and sleep rather than just breathing their teeth. So this is great. This is a great exchange.
I have a question.
Yeah.
Maybe it's an emotional question. What's your opinion on the position that tells mothers, never mind breastfeeding, give them the bottle because you're sour or salt there?
Yeah. Well, again, I would tend to think that most of us land on the planet with a pretty intact genome. I mean, the kids with real genetic disorders and things like that we see and we treat because we're healthcare professionals. You know what? When you base that into the world population of 7 billion people, most people land on the planet with a fairly intact genome, which means most women probably, if they're given the right environment, the right encouragement, the right circumstances, they're eating the right diet, all these things, they probably could do it. But there's sort of a mental resistance to it now. It's starting to change. Do you see that it's changing? That women are starting to, pay attention to their instincts and just do it?
A lot, but the thing is, the programs that are existing now in our island are promoting breastfeeding much more than before.
Yeah.
And even every day there is someone at the hospital, and then when the woman is giving birth, right at that moment they are consultant.
Like a lactation or something?
It's giving them advice.
Yeah.
And they even go home and they are always available if you have a problem. They come and they explain, they try to tranquilize. But on the other hand, I think there are some people that are not made. I've had patients that tell me, please, give me, I just don't want.
Yeah, a lot of it is a cultural thing. They just think it's like
they don't want
dirty or there's something wrong with it.
Yeah.
And plus you have formula companies. They're, in some hospitals, right there pushing the formula. And it's just easier and it's convenient. So that's changing too. All these things are changing. I just think women love their children. They want to give them the best. And if parents can be convinced that by breastfeeding you are conferring, something that is not only life lengthening but life enhancing, brain development. When people start to say, "Ooh, there's evidence for that," and I want to give my kid the best, I don't care what you say. I shouldn't breastfeed or I should give it. I'm going to do it because I love my kid. And this is how I love my child.
Just a film of Costa Rica hospital, and there I find moms that are encouraging breastfeeding every mothers and moms to breastfeed their child. In Costa Rica. Here we don't have it right now. but he does from Hollywood every month has a breastfeeding area from March to go with the child for breastfeeding.
Well, the other thing is, in terms of policy, is that, you know, some countries, in Europe anyway, I know they give women more time off to be with their child than they're born. And where's that? You're too good.
And they have this longer than, I don't know how many months.
9
they
months.
actually get the time from work, so they get half hours. And
Yeah.
you have to have a place
Or
that
are they
is
not getting
dry
this?
clean, and you have to have the foundation to store the milk, and it's very long.
Hey, we're getting it, you know? I mean, well, there's another thing that's real important, I feel here, and if I can just leave you with this, is that, okay, we are, you know, not getting biological or anything, but there's the plant kingdom and the animal kingdom. And, you know, we are primates, okay? We're human primates. We are in the animal kingdom. We could go extinct. And I think humans, because we have this big cerebral cortex, and we just, why shouldn't we feel privileged, okay? But we could go extinct in our own doing. I mean, just the air, food, species come and go. That's what macroevolution is. And you know what? I think if we're really smart, this is one of those things. We've got to quit threatening each other, we've got to quit killing each other, we've got to quit killing ourselves. And believe it or not, I think when people get it about the importance of the infant or the childhood feeding measure, the first 3 years of life, and how it can confer all these health benefits, our species is going to flourish. It's just going. But if we don't, and it sounds to me like I'm encouraged by this thing. I think you're telling me people are, you know, the workplace and policy changes, and you know, all of you came out here on Saturday. You know, I mean, I'm very encouraged. I'm really glad I came.